So today we will discuss about the NRP, the neonatal resuscitation program. It is recently updated in 2020. So its general principle that in all the other age groups, like in adults, whenever there is some kind of condition where there is asphyxia, we give priority to, like in emergency. Like in emergency conditions, we always give priority to circulatory system, like that the heart doesn't stop, like we do CPR and other kind of things, so that the heart doesn't stop. But in neonates, we give priority to the respiratory system, because in the in the womb the baby was not breathing on itself. It's the first time after the birth that baby is breathing, so we give priority to the respiration. So for adults, the order in emergency conditions is ABC, airway, breathing, circulation, and most resources are put into the in preserving the circulation. And for newborn, it's TABC, temperature, airway, breathing, circulation, and even in that most resources are focused on breathing, because it's the first time that the baby will breathe after birth. And temperature is also taken into account, because hypothermia may cause the baby to not cry, that is the breathing won't start. So what are the steps of NRP algorithm? So first we'll do the initial assessment. First step is initial assessment. That is, we will ask 3 questions. Did the baby cry? Is the baby of term? Or is the tone present in the baby? That is the flexion condition. So if all the 3 answers are normal, that the baby cried and the baby is of term and tone is present, flexion is present, then just clean the baby and hand over the baby wrapped in towel to the mother and start breastfeeding as early as possible. But if the baby, let's assume that if the baby is not of term, then treat the baby according to preterm. What are the manifestations of preterm, of the immaturity in the baby? Treat accordingly. If the tone is not present, that also signifies that baby is not of term, then treat accordingly, whatever the manifestation or pathology is present. But if the baby do not cry, that part will come under our NRP algorithm. So if the baby doesn't cry, then second step will be termed as initial action. So in initial action, we do these 3 things, these 4 things. First is take care of temperature, that is put baby under radiant warmer. Suctioning secretion, there is no routinely done, because it is only done when some secretion is present in the mouth or nose. So just look in the mouth and the nose. If secretions are present, then suction them, and if there is no secretion, then do this step, positioning of the baby, that we have to maintain the airway pattern in a straight manner. So we put the baby in a sniffing position, that is, we put a towel roll beneath the shoulder blades of the baby, so that, like, we put a towel roll beneath the shoulder blades of the baby, so that the head goes into slight extension and the airway becomes straight. And the 4th step is the tactile stimulation, that is, we do flicking on the soles and rub the back of the baby with towel or cloth, so that it gives some stimulation to the baby and the crying or the breathing starts. So just remember, initial action is TABC. Like we focus mainly on TAB, because circulation is focused in the adults, and in newborn we doesn't focus so much on circulation. So in initial actions, there are 4 steps, basically 3 steps, because suctioning is not done routinely. So there are 3 steps mainly, so 1 according each. So 1 for T, take care of temperature. 1 for airway, that is positioning of baby. Suctioning is not done routinely, only done when the secretions are present in the mouth or nose. Then 1 according breathing, like TA done. This is for breathing, like we do tactile stimulation to start the breathing. So generally, when do all these steps of the initial actions correctly, then 90% cases the baby starts crying. But if the baby still does not cry, Then we will assess the heart rate and the respiratory effort. So there is a this paradox kind of thing. Like first we discussed that we won't focus so much on circulation, but now we are going to assess the heart rate. This is because the earliest sign of hypoxia is decrease in the heart rate. So if the heart rate is decreased significantly, that means hypoxia is also significant. So that's why we assess the heart rate, and we assess the respiratory effort. Like is the baby is even trying to breathe? Okay. So after initial action, we will do assessing the heart rate and respiratory effort. So if the heart rate is in normally normal heart rate in neonates or newborn is 100 to 140. So if the heart rate is between 100 to 140, then mostly there will be no problem in the newborn, and the crying will start. But if the heart rate is that was discussion. If the baby is not crying even after initial actions, so the heart rate is above 100, that is within normal range, so that it means hypoxia is not that much. So assessing the heart rate and respiratory effort. If the heart rate is above 100 and the baby has labored breathing, and cyanosis may or may not present with labored breathing, so both of these things signify that the hypoxia is not much severe. So just support the baby's breathing. How we do that? Labored breathing, that means the baby is trying to breathe. That is, baby may not cry, but his breathing is started, but he is not able to do it properly. So we just increase the concentration of the oxygen more than room temperature. So we will use the oxygen hood, and we can use the CPAP, that is continuous positive airway pressure. That is, we give air to the baby with a positive pressure, so that his thoracic cavity doesn't have to create a pressure gradient. So if we give positive air to the baby, so his labored breathing will become to normal breathing. That is, he won't to have stress or work that much to complete his breathing. And this CPAP is very helpful in preterm babies because in them surfactant is lacking. So in preterm babies surfactant is lacking, so they have to generate a more of pressure gradient to start inspiration. So if in preterm babies we mostly use CPAP, so that they don't have to exert so much pressure. So labored breathing can be eased in preterm babies using CPAP. And what if the baby's heart rate is less than 100 and there is no breathing, or if the baby is doing the gasping, like he is doing like this, like there is some respiratory effort, but the breathing is not complete or not accurate. So this signifies that the hypoxia is very severe. So then we have to manually provide ventilation to the baby. This will be called as positive pressure ventilation. So in this we have two things: bag and mask ventilation, which is non-invasive, and one invasive technique, which is endotracheal intubation. So we assess the heart rate. If it was greater than 100, we started CPAP or hood. If it is less than 100, we started PPV. So we will discuss PPV later. So even still after positive pressure ventilation, if there is no response and the heart rate goes less than 60, then we will start the chest compression. So first step of the NRP was initial assessment. If all three questions normal, hand over to mother. If baby does not cry, initial action TAB. For T, take care of temperature. For airway, positioning of the baby, suctioning only if secretion are present. Then for breathing, tactile stimulation. Then assess the heart rate. Then do these things. So now, after positive pressure ventilation, if the heart rate goes less than 60 and there is no response in the baby, then we'll do chest compressions. So chest compressions, in CPR we do for adults. In CPR we just compress the chest with two hands over his chest. But in baby we never do chest compression alone. We always give chest compression with ventilation. So usually we give 90 chest compression and 30 assisted ventilation in 1 minute. Like one person is applying mask over the baby and giving chest giving ventilation, other person is giving chest compression. So the person giving chest compression will count every time he gives chest compression. Like we give chest compression along the, like assume like this is the chest of the baby, and we give chest compression. We put arms around our own hands around the axilla of the baby, and with thumb at the lower 1/3 of the sternum we exert pressure like this. So the person giving the chest compression will count like this, like 1, 2, 3, 4, 5. Like he will have to count the number of chest compression he is giving. So after every third chest compression, the person who is giving the ventilation to the baby will give one ventilation, will give one assisted ventilation. So like when the compression guy says 1, 2, 3, so at 3 the person giving the ventilation will give the ventilation once with the help of the bag. So generally we give 90 chest compression and 30 assisted ventilation in 1 minute. That is for every 3 chest compression we give 1 assisted ventilation using the bag and mask ventilation. So what is the procedure of giving chest compression? The most commonly used is, or more preferred way, is the 2 thumb technique, which is more efficient for the baby and less fatiguing on the doctor. Other technique is 2 finger technique. Like we use 2 fingers and press over the sternum like this. But assume like we have to give chest compression for 2 minutes, then and 90 every minute. So it will be fatiguing for the doctor to do this 2 finger technique. So we prefer this 2 thumb technique. The ratio rate is 3:1. Site is the lower 1/3 of sternum. So just put your arms around the chest in the axilla of the baby and your thumbs over the lower 1/3 of the sternum, that is below the nipples. So what the next step? So even after giving chest compression, if the baby does not improve and the heart rate is still less than 60, then we will give the adrenaline. So route is the IV, and as the umbilical vein is available after the clamping of the umbilical cord, so it is preferred. Dose is 0.1 to 0.3 ml per kg per dose. Dilation is 1 to 1000. So just an overview of the NRP. So after birth, 3 questions, that is initial assessment, then initial actions, TAB. For T, gradient warmer. For A, slight extension position of the baby. Suctioning is not routinely done, is done if the secretion present. Then for B, tactile stimulation to stimulate the breathing. Then we will do the assessing of the heart rate and respiratory effort. If greater than 100, we use O2 hood and CPAP. Less than 100, we will go to the step called PPV, positive pressure ventilation, in which we will use bag and mask and intubation. Okay, then even still if the baby does not respond and heart rate less than 60, we will do chest compression. Then if even after chest compression baby does not improve condition and heart rate is less than 60, we will do adrenaline. So time frame is also very important for this NRP. So you have to cram this time frame. So from the birth to the time that we are done with giving positive pressure ventilation, it should take just 1 minute. So in a baby that does not cry after birth, we should not waste time we should not waste time in anything. Like normally we do the clamping of the cord with a delay of 60 to 90 seconds to prevent anemia and these kind of things. But if the baby does not cry, we immediately do the clamping, because in 1 minute we have to do all these things. So if the baby does not cry after birth, we immediately do the cord clamping. We start the initial action, we do assessing of the heart rate, respiratory rate, and we do positive pressure ventilation in just 1 minute. And in next 30 seconds, we should assess the baby and do the chest compression. And in next 30 seconds, we will assess again and give the adrenaline. So what is volume expansion? So even after giving adrenaline, we can give fluids or plasma to the baby. So not plasma, we give IV fluids, normal saline, 10 ml per kg to the baby, and it is not routinely done. It is done only if there is evidence of shock. That is, example, significant antepartum hemorrhage in mother, bleeding in baby during after birth. So why will give volume expansion? Let's assume that the baby has baby is in hypovolemic shock due to decreased volume of the blood. So even if the baby was breathing normally, but he is into shock, that's why he is having hypoxia. So that's why we will give volume expansion, but only in the cases where there is history of shock. When so how long for we should continue the neonatal resuscitation? We will do all steps of the NRP, and we will keep doing them for 20 minutes. And even after 20 minutes, if there is no sign of life in baby, that he does not cry, he doesn't start breathing, then we will take advice of expert doctor, that is the senior pediatrician, and then stop the resuscitation and inform the parents that the baby did not start breathing and the baby has passed. So now detail of the positive pressure ventilation. So it can be invasive, that is endotracheal intubation. It can be non-invasive, that is bag and mask ventilation. So what is bag and mask ventilation? It is the first procedure under PPV. So equipment in this called is AMBU bag, that is artificial mechanical breathing unit. You just have to cram these kind of things. The only thing that we have to understand is the gripping. So gripping, we use the CE technique. So what is CE technique? So assume this is baby. This is baby's face, eyes, nose, mouth. So proper application of the AMBU bag is like it should cover both nose and mouth. It should not extend up to eyes and should not extend towards the chin. Okay. So how we do proper gripping? We grip baby like this. Like this is our hand. We do like this. With thumb and index finger, we grip the mask. With these three fingers, we put mid finger below the chin, the index, the ring finger on the mid part of the mandible, and the little finger on the handle of the mandible, with the angle of the mandible. This is how we grip the baby. So this forms a C shape over the mask, and these three fingers form an E shape over the mandible. So this is CE technique of the gripping. So now response. So earlier response to bag and mask ventilation will increase in the heart rate. Later baby may start crying also. So what if the baby doesn't show any response to the bag and mask ventilation? We do not immediately shift to endotracheal intubation on the next step. We will do this step, which is mnemonic as MR SOPA. So this is called as ventilation corrective steps, because most commonly we have to do PPV, initial assessment, initial action, and PPV in first 60 seconds. So most of the time it occurs that we get hyper excited, or that I'm not getting the proper term for it, what I should say. We do not properly follow the steps, so we do the ventilation corrective steps. Or this is MR SOPA. So this is not just to be crammed. Also these points are to be crammed. So there is one thing. There is absolute contraindication for the BMV. So it is in the congenital diaphragmatic hernia, because what happens in this condition is that, like, assume like this is our thorax, this is our diaphragm, but the diaphragm has a hole in it. So these are our lungs, this is our trachea, lungs, this is our intestine loops. Due to a hole in the diaphragm, intestine loops enter the thoracic cavity. So in BMV, remember, the mask is applied over the face and over the nose, and even in the MR SOPA we open the mouth. So air is entering both trachea and the esophagus. So if the baby has congenital diaphragmatic hernia, then the air will enter the esophagus into the intestinal loops, and they will further herniate into the thoracic cavity, and the lungs won't get space to expand properly. So baby was already going to the hypoxia, the lungs was not inflating properly, and now the baby has to further generate a force against the intestine to expand the lungs. So that's why in congenital diaphragmatic hernia there is absolute contraindication for the bag and mask ventilation. We straight away do the endotracheal intubation. So endotracheal intubation is an invasive method. For this we use a laryngoscope, and the laryngoscope blade used in it is the straight blade, and in adults we use the curved blade. So all this is to be crammed. So what is EPGAR score? So whatever, so EPGAR score is just kind of a mnemonic table. So it is a valid topic, EPGAR score, but in it the abbreviation of the EPGAR is just to concept, and the actual parameter are written with the black pen. So like A for appearance, pulse rate, grimace, activity, and respiratory effort. And this is not to be anything to be, nothing is conceptual, it's just to be crammed. What about neonatal sepsis? Then comes to the topic of the neonatal sepsis. So this also is topic to be crammed. So for neonatal sepsis, come to the features. So in features of, like, there are no specific features of neonatal sepsis, like it is an infection, and the features will be confusing for us, like that the baby is not breathing properly, or it has anemia or shock, or it is directly shock, or it is shock caused due to sepsis. So there is overlapping of symptoms of different pathology. So if baby is sick, like if any kind of pathology is present in the baby is not breathing properly, baby is having shock, baby is having seizures, anything, if the baby is sick, then we will suspect the neonatal sepsis, and we start a prophylactic or empirical therapy, and we will wait for the investigation results for the confirmation of the sepsis. So features of neonatal sepsis: any sick baby, poor feeding ability of the baby, or lethargic baby. So these are the things. What should we? Okay, let's come to the investigation. So investigation, the definitive investigation, the gold standard investigation is the blood culture, which will confirm the presence of the infection or microorganisms in the blood, that is septicemia leading to the sepsis. So, but the thing is that blood culture results come in 3 to 5 days. So for a rough idea, we do the screening test for the rough idea of the neonatal sepsis, and the screening test for neonatal sepsis are TLC and these things, TLC and absolute neutrophil count. So normally adults in sepsis, both of these will be increased, but in newborn both of these are decreased because the immune system of the neonate is not that matured. ESR will be elevated. Just remember this much, that ESR will be elevated like any infection in adults. CRP will also be raised. CRP will be more than 1 milligram per deciliter. But the thing is that CRP does not increase just after bacterial infection. It takes time. But there is a marker procalcitonin, which levels increase earlier than the CRP rise. So it is more sensitive than the CRP. So it is used now more oftenly. So we also can do lumbar puncture if we suspect meningitis. We can also do chest X-ray if we suspect pneumonia. So what is the management of the neonatal sepsis? So like we told that we always suspect the sepsis, neonatal sepsis, the baby is crying or baby is sick. Sorry, if there is any kind of sickness in the baby. So without waiting for the investigation results of the investigation, we will start the empirical therapy, assuming that the baby is sick. So it must have neonatal sepsis. So we will do this penicillin, and one penicillin group antibiotic, one aminoglycoside. Like we can use ampicillin or gentamicin from this. If there is no response, or we suspect severe condition of sepsis, like there is some signs of shock or meningitis, then we will empirically, like without waiting for the results of the lumbar puncture or any other investigation, we will straight shift to third generation cephalosporin or aminoglycoside if there is severe sepsis, or if the baby is not responding to these therapy. So after blood culture report comes, like if it was positive or which organism was present, then we will shift to antibiotic accordingly. It was gram positive, gram negative, or that kind of thing. So how long for we have continued the antibiotic therapy? This depends on the blood culture result and the type of infection. For example, if the culture negative sepsis, like the blood culture test report came after 4 to 5 days, but it is negative, so there is no microorganism present, but there were features of some sickness in the baby, or features of like pneumonia and anything, that because of which we started the antibiotic therapy. So in this condition, we will continue to the antibiotic therapy for 1 week. The blood culture was positive, but there is no meningitis. That is, blood culture was positive some organism, but there is no severe infection. Then we will continue antibiotic for 2 weeks. But if there is meningitis present, irrespective of the blood culture reports, if there is meningitis present, like confirmed with the help of imaging techniques, or confirmed with clinically, so then we will do the antibiotic therapy for 3 weeks. Now come to the birth asphyxia. Okay, birth asphyxia, it's all to be crammed. Okay, now come to the HIE, that is hypoxic ischemic encephalopathy. So its manifestation in later stages of life is like if the baby was term and had hypoxic ischemic encephalopathy, then the pathology which will occur is the parasagittal infarcts, which will lead to spastic quadriplegia in later stages of his life. If the baby was preterm and had HIE, then the pathology will occur is periventricular leukomalacia, and the manifestation in late stages of life will be spastic diplegia of lower limb. So what are the features or manifestation of the HIE in the neonatal period? That is the features which will be visible in the neonate, which will signify that the baby is having hypoxic ischemic encephalopathy. So for this we have this Sarnet and Sarnet staging. So in this, there is stage 1 to 3. There is some features of CNS involvement, ANS involvement, and what will be the outcome of the baby. So involvement of CNS, that means that the CNS is excitable or not. So in stage 1, which we consider mild, the CNS is excitable. In this stage 2, CNS is depressed. In this, CNS is not functioning. So this is easy, just remember these. We have to rate 3 main factors: CNS involvement, ANS involvement, and outcome. So, and in CNS there is consciousness. So in stage 1 the CNS is excitable, so consciousness is normal or hyper alert. In stage 2, baby's CNS is depressed, so consciousness will be lethargic, and here CNS is not functioning, so comatose. Here reflection will be present because the baby is hyper alert or normal. Here baby is lethargic, so reflexes are sluggish or decreased. Here baby is comatose, so reflexes are absent. Seizures are only present in the stage 2 because stage 1 is mild, and in stage 3 the brain went under so much hypoxia that even the seizures are not manifested in the baby. So seizures are present only in the stage 2. This is a thing to be remembered. Then the ANS involvement. ANS involvement is also according to this. Like in stage 1 CNS was excitable, so here also the excitatory condition, that is sympathetic overactivity. Here was CNS were depressed, baby was lethargic, so here also there is overactivity of the parasympathetic system. So accordingly, pupil size and heart rate and the outcome. So investigations are then all things to be crammed. Okay, it is easy and it is to be crammed. What about neonatal seizures? So neonatal seizures is also to be crammed. The only thing to mention is the type of seizure. So in neonates, most of the seizures occur within first 24 hours of the life, and most of them are the subtle type of seizures. That is, there is minimal involvement of eyes, of limbs, or mouth, or facial or lingual region. Because in the babies, the brain is not that much matured. So if even if there is abnormal electrical activity, which is we know as seizure, even if there is some abnormal electrical activity which is started due to immature electrical circuits in the brain, it does not spread all over the brain. So it just manifests as minimal movements, so which we will term as subtle seizures. So okay.